So, thank you. So, respected senior doctors and friends, at the outset, my sincere thanks to my well-wisher, respected GVK sir, for giving this wonderful opportunity. So, my topic is gastroparesis, the causes and management. So, let me start with the introduction. What is gastroparesis? So, it's a complex gastric motility disorder which is characterized by nausea, vomiting, and other symptoms associated with the delay in gastric emptying in the absence of mechanical obstruction. So, it represents a dysfunction of the complex neuromuscular coordination which is required for normal gastric peristalsis. If you just see the normal gastric emptying and what happens in gastroparesis, the stomach is structurally normal but only functionally impaired. So, it refers to the impaired movement of food from the stomach to duodenum due to dysfunction of the gastric muscles or the pacemaker cells. So, normally the coordinated activity of the fundus, antrum and pylorus, they ensure the proper digestion and emptying. So, in gastroparesis, this coordination is lost. The most common cause, we all know, it's hyperglycemia. So, the key mechanism, vagal neuropathy, enteric nervous system dysfunction and loss of interstitial cells of Gajal. So, yes, small word about normal gastric physiology. So, gastric emptying requires three important things. One is fundic relaxation, secondly the antral contractions, thirdly the pyloric relaxation. So, to all have these three things, neural control through the vagus nerve is required and the pacemaker activity from the interstitial cells of Gajal. So, all have to work in synchrony. So, this is the normal gastric physiology. So, if you just see this thing, everything have to work, and when all these components work in synchrony, the gastric contents are efficiently emptied into the small intestine. So, moving on to the gastroparesis, what are the common causes of gastroparesis? First, most common is diabetic gastroparesis, second is idiopathic, third is post-viral gastroparesis, then comes the post-surgical gastroparesis and drug-induced gastroparesis. So, next thing is neurological disorders, connective tissue disorders, endocrine and metabolic causes, critical illness, and lastly, the infiltrative diseases. So, all these things. So, the key points, diabetes is the most common cause and always review the patient's medications before coming to a conclusion. So, as I told before, normal gastric function and what happens in a gastroparesis. So, every cause of gastroparesis ultimately disrupts the delicate coordination between the nerve, muscles and pacemaker cells of the stomach. So, what are the causes of gastroparesis I told and what are the incidents of all these things? So, let us see what happened inside the stomach in a case of diabetes. So, to understand this condition, we need to revisit the impact of hyperglycemia. So, years of uncontrolled diabetes silently damages the vagus nerve, the critical pathway connecting the stomach motility. So, this is a classical example of diabetic neuropathy. Instead of affecting the feet, it affects the stomach. So, what is the final result? The stomach becomes a slow engine, unable to push the food forward efficiently. So, this is the thing what happens inside the stomach. So, what is diabetic gastroparesis? So, it's a complication that occurs in type 1 and type 2 that is uncontrolled, and high blood sugar levels affects your stomach muscles and cells, causing problems with how food leaves your stomach. So, these are the things. So, to understand why this happens, we need to look at the underlying mechanism. So, the vagus nerve dysfunction, how the interstitial cells of Gajal and the reduced nitric oxide synthase, all these things have an impact on the insulin resistant, AGEs, inflammation and oxidative stress and the macrophages. So, why this matters? So, gastroparesis, it's not a gastrointestinal issue. So, it disrupts the very foundation of diabetes management. So, it is always delayed and it becomes a dangerous cycle. The food absorption leads to unpredictable glucose spikes and the patients may inject insulin expecting the food absorption but the food arrives late. So this mismatch increases the risk of hypoglycemia. So if you just see the incidence of gastric complications, the gastroparesis, nearly 5% in type 1 and just 1% in type 2 diabetes with an incidence of 10 years, and 30 to 50% of long term of diabetes have these complications. So what really happens, as I told before, three major mechanisms. One is autonomic neuropathy, where the vagal nerve is damaged. Second is loss of interstitial cells of Gudgel, which leads to impaired gastric pacemaker activity. And third is smooth muscle dysfunction, where it leads to weak or uncoordinated contractions. So all these things, it results in delayed gastric emptying. So what is the pathophysiology in case of long-standing diabetes? So chronic hyperglycemia, it leads to autonomic neuropathy, particularly affecting the nerves, and as I told, because all these things, they ultimately results in delayed gastric emptying, which directly explains the symptoms what the patient experiences. So what are the clinical features? Bloating, indigestion, early satiety, and extended fullness, nausea or vomiting, abdominal pain. These are the common symptoms what we come across day-to-day things. So moving on to the complications of gastroparesis. If you have recurrent episodes of gastroparesis, it leads to dehydration, malnutrition, and blood sugar hikes and irregular sugar levels and daily symptoms. So what are the difference between a normal and a gastroparesis? So these are the things. The motility is affected, the pacemaker activity, emptying is delayed, and the symptoms will be there. So with this background, what are the clinical challenges what we have today? So diagnosing gastroparesis is often delayed, and many patients are treated symptomatically for years. So these are the things: gastric emptying and severity of gastric paresis. So why the treatment is important? If untreated, gastroparesis may lead to malnutrition, dehydration, and worsening glycemic control. So breaking this cycle is the primary goal of management. So what is the management? So management is a multifaceted approach. Dietary modifications, small frequent meals, low fat diet, and adjusting the insulin timing and the prokinetic therapy as an add-on medical thing. Finally, the most important thing is patient education. So understanding the condition, recognizing the trigger symptoms which leads to the thing. So lifestyle modification, eat meal frequent intervals, avoid foods with fat and fiber, drink lot of fluid, avoid alcohol, eat slowly. These are the things. So these three important aspects. One is medical management, secondly with some type of surgical intervention, and thirdly endoscopic treatment. So we all know the management of things. So this, once again, the primary treatment comes with lifestyle modification, medication, surgery. The thing is, moving forward post-diagnosis with gastroparesis. So we need to prioritize the mental health, keep up with the hydration and sleep, seek out community support, and ask the doctor about the appropriate nutrition and accuracy. With all these type of things, only 70% of the patients respond adequately to dietary and medical management, necessitating a structured escalation pathway. So first comes the nutritional and dietary modification. Second is the pharmacotherapy. If pharmacotherapy fails, we can have an endoscopic therapy. If all three fails, there is a need for device or surgical rescue. So foundation is dietary management, as I told before. Second comes the established pharmacotherapy with anti-dopaminergic drugs like metoclopramide and domperidone, and the serotonin modulators, 5-HTN4 agonist and the 5-H3 antagonist. So third, the endoscopic breakthroughs. So nearly 73 to 85% clinical success rate and 36 month demonstrate durability with this thing. Lastly, surgery. So surgery is durable but high risk, only the last resort. So we have lot of restrictions with this thing. So what is the future? So everything is individualized and targeted care. So we need to evaluate global and regional function, target the physiological deficit, individualize the therapy, measure the real-time response. So the management paradigm has shifted from one-size-fits-all approach to individualize therapies based on regional physiological evolution, endoscopic innovations, and receptor-specific pharmacology represent the new frontier of gastroparesis care. So to conclude, diabetic gastroparesis is often invisible, often misunderstood, and frequently underdiagnosed. But behind every delayed stomach is a delayed diagnosis and a patient waiting for answers. So let us not just treat diabetes as a number. Let us listen to the story behind it. To conclude, behind every uncontrolled sugar level, there may be a delayed stomach. So thank you all for your patience here.